So we will go ahead and get started. I'd like to welcome you all to the second virtual town hall from the Program for the Elimination of Cancer Disparities, or also called PCAD. And today's event is focused on addressing disparities in COVID-19 and cancer in the Latino, Hispanic, and immigrant communities. For our viewers, we're not able to see or hear you, but we want to encourage you to ask questions in the chat feature of Zoom. We'll be drawing on these questions throughout the event, so everyone should be able to see the chat. So if you have any other thoughts or resources you'd like to contribute, please do. My name is Ashley Houston, and I'm an assistant professor in the Division of Public Health Sciences at Washington University. And before I introduce our panelists, I wanted to contextualize this conversation by sharing some of the latest data on what these disparities look like. And as I talk about these data, I will be describing cancer and COVID among the Hispanic Latinx communities. And we chose these terms because of the way the data were collected and also based on the input from our stakeholders. And our panelists will give more detail regarding the diversity of these communities throughout this panel. I'd like to just switch over and share my screen with you all. There we go. And so cancer is a leading cause of death among those who identify as Hispanic Latinx, and these communities make up about 18% of the total US population. In 2018, there were 150,000 new cancer cases and 43,000 cancer deaths among those who are Hispanic Latinx. For all cancers combined, those who identify as Hispanic Latinx have 25% lower incidence and 30% lower mortality compared to non-Hispanic Latinx whites. Although certain types of cancer, like liver cancer, are twice as high among those who are Hispanic Latinx. In addition, it is important to note that more than 3 million Hispanic Latinx Americans live in the US territory of Puerto Rico. And this is important because we see variability in cancer risk across these data from the US and Puerto Rico. For example, prostate cancer rates in Puerto Rico are higher when compared to those in the US. Those variations are thought to reflect the different exposures, behavioral risk factors, and screening. And when thinking about Missouri specifically, Siteman Cancer Center primarily serves patients in 40 counties in Missouri and 42 counties in Illinois, so 82 counties total. And this geographic area is considered the primary geographic catchment area, representing the counties from which the majority of Siteman patients live. In 2018, 131,000 of those who are Hispanic Latinx resided in the catchment area, and 77 were diagnosed with cancer. In the most recent 5-year period, the incidence for all cancers in Missouri was 270, which is lower than the national average of almost 350. The recent trends for the US and Missouri is that cancer incidence is decreasing. And when looking at Missouri as a whole, there are several counties with very high incidence of cancer among those who are Hispanic Latinx, and these are outside of the 82 county catchment area. And those counties are McDonald County, Pettis County, and Jackson County, which is where Kansas City is located. And St. Louis City and St. Louis County are both lower than the national average. However, the recent trends also show stable and not decreasing, and they're not decreasing like national trends. For those who are Hispanic Latinx living in the city of St. Louis, cancer incidence is 57% lower than the national average. However, mortality rates are 22% higher. And thinking a little bit more about the COVID data by race and ethnicity is somewhat incomplete in many places, making it unclear as to why Hispanic Latinx communities have been infected at higher rates. And last week, the New York Times described some of the challenges of identifying COVID disparities at the national level. For COVID in the United States, those who identify as Hispanic Latinx are 3 times as likely to become infected as their white peers, and they are nearly twice as likely to die from the virus. Counties with a greater percentage of those who are Hispanic Latinx also tend to have features that are likely to make individuals more vulnerable for COVID, like a greater number of people living in a single household, younger populations, and hotter weather with individuals staying indoors. In addition, sheltering in place may not have occurred for Hispanic Latinx families with members who work in industries that never shut down. and immigration status and language are also barriers to reporting. In the state of Missouri, we're also seeing disparities in the number of cases. And while those who are Hispanic Latinx make up approximately 4% of the population, they make up about 15% of the COVID cases. And disparities in death are not observed here, but they should be reviewed with caution since there are limitations to these data. And in the city of St. Louis, we're seeing a higher case rate for those who are Hispanic Latinx when compared to non-Hispanic residents. And to give a snapshot of the county, St. Louis County, we're also seeing higher rates of COVID among those who are Hispanic Latinx. The rate of new diagnoses among those who are Hispanic Latinx residents is about double the rate when compared to non-Hispanic residents. I'm going to stop sharing my screen here and take the opportunity to talk a little bit more about these disparities and what can be done to address these disparities. And I'd like to introduce our panelists. Today we have Diego Abente, the CEO and President of Casa de Salud, Dr. Julia Lopez, an instructor in the Division of Infectious Disease and a researcher in the Institute of Public Health at Washington University School of Medicine, Yvonne Berlinger, Executive Vice President of Affinia Healthcare Foundation and Affinia's Vice President of Development and Community Relations, and Dr. Hiram Gay, Associate Professor of Radiation Oncology at Washington University School of Medicine. And to start us off, why don't we have each of you tell us a little bit more about what you do and what you're seeing in your work in terms of COVID and health disparities. Diego, would you like to start?
Sure, yeah, well, first of all, good morning and thank you very much for the invitation. It's always great to talk about these very important issues and bring to the forefront how important it is for the entire community to be considered when we think about how we are responding to COVID. So my name again is Diego Bente, and I'm the president and CEO of Casa de Salud. Casa is a 10-year-old nonprofit based in St. Louis, and our mission is to facilitate and deliver high-quality clinical and mental health care services to our region's under and uninsured. And we focus, of course, on immigrants and refugees who encounter barriers to accessing these types of services from other sources. So last year, we engaged with our patients and our clients well over 14,000 times, and we saw folks who represented 60 different nationalities in 30 different counties. So we're proud of the diversity of the folks that we're able to serve. And we do that, we serve these folks in three really, really important ways. Our core service is the provision of clinical health care for folks who can't access that type of care elsewhere. And we do that through incredible partnerships with volunteer medical providers. So I can't stress enough how fortunate we are to be able to work with doctors who volunteer their time. In order for our patients who come to Casa to receive continuity of care or specialty care if they need it, we provide a really incredible high-touch case management service that we call GUIA, Guides for Understanding Information and Access. And so GUIAs primarily help patients navigate our healthcare labyrinth and become their own best advocates. But they also take the opportunity as they're interacting with the system to create system-level advocacy, helping hospitals and doctors' offices be in a better place to serve the entire community. That gets back to my opening statement. And finally, and most recently, we launched a mental health care collaborative in response to our patients' desire to receive mental health care. So we're now working with 20 partners, and we're collaborating to provide high-quality mental health care in this community while helping therapists also become more culturally competent and able to provide service for our changing demographic in St. Louis, but across the nation. And so through those services, what are we seeing as a result of COVID? We're seeing a lot of things, and we're seeing a lot of evolution. And I think one of the themes as we continue to experience the season of COVID that we need to keep in mind is that this is an evolving situation, which is creating evolving consequences in the entire community. So what we do see is that Latinos are feeling left out. They are struggling with understanding some of the messages that are in the community because they're not very clear in English, which means that when you translate it into another preferred language like Spanish, that inconsistency and that lack of consistency really comes to the fore. And these are folks who are traditionally feel like they aren't being well served by the system, and that the system is not there to serve their needs. And so providing an inconsistent message And not providing all messages in preferred languages is something that exacerbates that feeling of sort of feeling alone. I've said a few times before, and I really believe it, understanding COVID is not something someone wants to go look up on WebMD, right? They want to be able to speak with somebody who can walk them through all the stress and anxiety of our first generationally global health pandemic. And we're not quite there yet. And so our community needs to do better. Service providers need to do better about communicating consistently and accurately, both in English and preferred languages, and do that in a way that the entire community feels like they're being spoken to, not just a particular portion of the community. And I think that the other thing that I'm seeing as I'm hearing from our frontline folks is that there's a real difficulty between understanding the risks of accessing care and delaying care. And I think that's particularly important when we think of chronic illness and we think of things like cancer, where chemotherapy and other interventions need to happen regularly. I think that there's, out of an abundance of caution, the real desire to delay care and to believe that given an opportunity, maybe delaying care is the right choice. And that's a difficult, I think it's a very individual choice, and it depends on the patient and the condition, but it's also more often than not, it's probably putting patients in a precarious situation, because ideally they should be seeking that care, and we should be doing enough to provide them the opportunity to do that safely. And that's not just about the facility where they go to access that care, it's about how they get to that facility, right? So we have to think about our folks where they are, and from their perspective, what are the challenges that they normally encounter with accessing care, just getting to those facilities. And once they're in those facilities, how are they being treated, and in what language in particular, and with what cultural sensitivities are they being treated for their conditions, which would hopefully, if it's done right, encourage them to return and encourage them to spread the word in the community that there are services out there that are really thinking about their needs. So I think I'll leave it at that for just the beginning comments, but I do think that there's a lot that we can do, and forums like this help us think outside of our own boxes and improve our services and reach our communities more genuinely and more consistently, and that's really important.
Dr. Lopez?
Let me unmute myself. Yes, thank you for having me. Dr. Julia Lopez, pronouns she, her, hers. I am really glad to be on this panel with such awesome people, in which we can talk about some of the most important aspects of COVID disparities. My work has been quite kind of a trajectory, I would say. I started in community mental health for a number of years, doing clinical practice. I am a licensed clinical social worker, as well as my PhD in public health. And so for me, I think I have always had racial disparity, health disparity outlooks in every kind of piece that I've ever touched or worked in, not only because I also identify as a first generation Latina, but also the intersectionality as it relates to sexual and gender minority individuals, so LGBTQIA+. And so for me, there has been that kind of one-on-one conversations that I've been having with a number of different clients, since I do still practice mental health therapy in the South City area, where currently we're doing everything therapy at this time, but I've definitely seen an increase in folks talking about kind of some of their experiences as it relates to the healthcare system. And that is unfortunately a truth that I see too often when it comes to the type of care, the consistency of care, and what people feel, the stigma that is related to whatever identities they hold. And so for me, I see a lot of BIPOC people, so Black, Indigenous, people of color, with the intersectionality of sexual and gender minority health. And so, you know, there are a lot of competing aspects as it relates to why someone is able or not able to engage in the care that they need. And that level of accessibility is unfortunately a hard truth that we as providers need to be really considering and paying attention to, and making some true movement. I think, you know, during these particular times of the pandemic, coupled with the ongoing importance of anti-racist work, that we cannot really disentangle those things as it relates to COVID, and that these disparities are not just because they came out of nowhere, but rather that systematic oppression is the rationale and reason behind why we see the things we see and how those are impacting the different communities of color. And so I think that if we don't talk about anti-racist work in the work that we're doing in health disparities, then I think that we're really missing the boat in all of its intensities.
Yvonne?
Hello, I'm Yvonne Buehlinger, and I've worked at Affinia Healthcare now for over 24 years. So this work for me is not just a job, it's really a mission and a passion. Affinia Healthcare is a community health center, non-for-profit, to address the needs of immigrants that were coming into the St. Louis region way back at that time. And through the years, our services and breadth of services that we provide have expanded to continue to address disparities amongst those who are the most vulnerable and need our care most. So currently, Affinia Healthcare serves over 43,700 patients per year. That equates to approximately 250,000 clinical visits for our patients. That does not include all of the other visits that or interactions that we have with patients to help them navigate and access a variety of services, education, information, and WIC, for example, which is also a service that we offer through which we reach about 60,000 individuals per year. So we are a very extensive organization, and we have many locations in the city of St. Louis. We have 10 locations, and in the county, 2 locations. Some of those locations are embedded in other entities whom we partner. For example, the St. Louis Dental Center, which is located in Lafayette Square. That is a partnership of A.T. Still University and Affinia Healthcare that came about a few years ago, and it has really allowed us at Affinia Healthcare to expand dental services beyond primary care to include very much needed specialty dental services, for example. We have collaborations at 3 schools, area schools where in areas that are very under-resourced. One of those is Normandy High School in the county. And we have many other collaborations in terms of specifically the Hispanic community. Those individuals make up approximately 11% of our patients, so that's about 4,000 individuals that identify as being Hispanic. And the majority of those patients need interpretation services. We have many staff who are also bilingual, even though for interpretation of clinical care, we rely on contracted outside certified medical interpreters, which is really critical for the quality of that interpretation in a medical clinical type setting. So access is not just being located in a certain community, which also is part of how we create access by having many locations so that we can provide those in a way that is accessible through public transportation, for example, to a majority of people in under-resourced areas in our community. So, but also access means that access to language services, for example, and the navigation and other aspects of being able to provide care in a way that people are actually able to benefit from. During this COVID crisis, we have been extremely proactive. From the beginning, when the crisis hit our area here in St. Louis, we knew that the people that we serve would be highly impacted because of the disparities that are prevalent in our patient populations. Of the 43,000 patients that we serve here in St. Louis at Affinia Healthcare, 90% of those patients have incomes under 100% of poverty. 70% of those patients are Black, and as I mentioned earlier, about 11% of our patients identify as African American. 4,000, about closer to 44,000, 4,400 of our patients are homeless, who are part of, they either stay in shelters or encampments, that sort of thing. But the remainder of our patients, a large percent of them are very housing insecure as well. So all of those factors are negative social determinants that impact the populations we serve. So because of all of those things and many others, we felt compelled to seek the resources to immediately deploy COVID testing in our main location starting on April 2nd, that was the date, which is in 63106. That is the zip code that is one of the poorest zip codes in our state, as well as has some of the worst situations in terms of health and other socioeconomic issues. So, and that is also very close to the Biddle House shelter that is the largest shelter in our region. So we started doing testing there, then we expanded that effort and provided the first testing location in South St. Louis City at our 3930 South Broadway location, which is located across from St. Alexius Hospital. And that is where we see a large percent of our Hispanic patients. Approximately 40% of the patients at that South Broadway location identify as Hispanic. So it was really important for the Hispanic community that we, and all of the community, everyone in our region, that we offered testing at no cost in an accessible manner. To date, including testing at those locations and other locations where we also partner with the Missouri Department of Health and Senior Services for mobile testing services in hotspots in under-resourced areas. We have provided over 8,000 tests. Approximately 6% of those COVID tests have been for people who have checked the boxes as being Hispanic. A number of people don't self-identify and leave those boxes open, but that's approximately also what we estimate in terms of the proportion of the population being tested. So it's a significant effort for us. It feels like a race to try and keep the community abreast of what is going on with the rates of infection and exposure to COVID-19. With that testing, we provide education and we provide resources as we do with all of our efforts. One other thing I will say is that the pandemic has created a situation that hampers outreach efforts. We are so used to being able to go in person and knock on doors, for example, to have big events like health fairs. At our South Broadway location alone, we have an annual back to school health fair where each year we provide all kinds of education, have many partners that set up tables, that sort of thing. And typically we have over 1,000 people attending that one event, and that's just one of many. That's our largest health fair event for back to school for our patients. So the pandemic has really changed how we address providing patient care. The addition of telemedicine, of course, and managing schedules differently, managing our waiting room areas differently to provide the most protection to everyone so that they are safe. adding all kinds of health education, as Diego mentioned. Not only is the information sometimes confusing, but the factors and the information has changed and has evolved over time. So all of that creates a challenge of you create materials, you put it out there in the community, and then you turn around, you have to revise and change. And now those materials are outdated, but somebody has them. And they might be thinking, oh goodness, I need to make an appointment, and rather than just come and be tested. And which is the case right now. You can just come and be tested. You don't have to be symptomatic. You can just, if you just want to know because you think you might have been exposed, so that you can better protect yourself and your family and those around you. You know, you don't need an appointment. You don't need to have symptoms. So all of those things are challenges that we are seeing. And through all of those challenges, again, we make a conscious effort and a constant effort to look at disparities, equity barriers, language access, and economic access as well. Since I have this moment, I will encourage everyone to vote on August 4th, those elections, and mark yes on Amendment 2, which is voting for Medicaid expansion. 40% of our 43,000 patients at Affinia Healthcare have no health insurance. And that is a lot of people in our area. We are the community health center in Missouri that provides the most care to the uninsured. This would make a tremendous difference for all those patients. People delay care when they feel they don't have a way to afford that care, not just the primary care, but all of those other specialty services that they might need. And certainly if they end up in the hospital or need to go to a hospital, that is very expensive care. So please vote yes on Amendment 2 on August 4th.
Thanks, Yvonne. And Dr. Gay?
Hi, can you hear me?
Yes.
So I'm a radiation oncologist at Siteman Cancer Center. Originalmente soy de Puerto Rico, soy boricua, and I specialize in prostate cancer and head and neck cancer. COVID-19 has changed how we practice medicine. We're doing more telemedicine. We're doing a lot of social distancing. Patients are wearing masks. We're particularly worried about our cancer patients because the mortality in cancer patients of COVID-19 is much higher than the general population. We're dealing with usually elderly patients with other medical conditions like diabetes, hypertension, lung problems, etc. So, we are being very careful with our patients. For our prostate patients, we've tended to delay treatments since the cancer is more forgiving and we can do hormonal therapy to slow down the cancer and buy us time till we can do the radiation. For head and neck patients, time is of the essence. So those patients we haven't delayed, but it's certainly changed quite a bit, how we practice, and we don't see things changing for quite some time. But that's the main worry for us. It's the higher mortality rate in cancer patients from COVID-19.
And Dr. Gay, how has the pandemic impacted cancer screening? And are you seeing any disparities in that right now?
The minority of the patients I see are, Hispanic, Latino. I am currently treating a patient who is Mexican, who's receiving palliative radiation for prostate cancer. What's changed was that when we were preparing for the surge in cases, some of the ORs were changed or were ready to accept patients in ventilators. So surgeries went down quite a bit, biopsies for cancer, etc. So that has slowed down patients coming in for care. Of course, some patients are scared. Really, there's a lot of precautions in the hospital. Patients, as soon as they enter, they get screened with the temperature, etc. So we make it as safe as possible. But I think the fear from patients of going to the doctor, that has delayed care. Surgical procedures have gone down. Now the ORs have reopened and things are pretty much back to normal. But there was a time that there's been some delay for some patients, yeah.
And this is a question for Diego. So who exactly are we referring to when we speak about the Latinx, Hispanic, and immigrant communities? And how is this pandemic affecting them?
Yeah, that's a tremendously important question now, as English speakers and bilingual folks come around tables to work out ways to communicate with folks who prefer Spanish and other languages to receive their information, right? Because it starts with how we're referring to folks. And so I'm going to share with you, without taking up the entire remainder of our time here, because this is truly a very, very deep and important question, my personal journey around the terminology, and then from a practitioner's standpoint, the questions I ask myself to ensure that the service that we're providing at CASA is that the folks that we want to serve are receptive to the terminology that we use, right? Because in many respects, my opinion is my opinion, and what really matters from CASA's perspective is are the patients that we want to serve, or the clients that we want to serve, hearing us when we speak to them about the services that we provide. So Latinx is a term that came about around about the 2014 era, 2013, 14, and 16, was really coming into sort of the vernacular, if you will. More people were hearing about it. And it was intended to express the gender fluidity that we now embrace, I hope, as a community, but didn't, years prior. And so the Spanish language utilizes gendered words, right? So Latino refers to only men and or the entire group, and Latina refers to only women if you're saying it in Spanish. And so for I think English speakers, it's particularly troublesome because they don't have that challenge as they speak in English. And so Latinx was a term that was sort of constructed to really bridge the gap between the romantic language and the reality that humanity is encountering today, which is that there is fluidity and that folks should be able to identify in ways that inspire confidence and that don't force them into a box that they're not comfortable with, right? So Latinx is a term that a lot of folks are very comfortable with because it allows them that fluidity, and they identify with that. And as on my personal journey as a Gen Xer, late Gen Xer, not that old, it's a term that I came to learn later in life, if you will, but came to embrace because I understand, especially as someone who's in the nonprofit space, that it's important to allow people to feel comfortable with the way that they identify. And as a provider of services, if you start off by putting people in boxes that they aren't comfortable in, your service delivery is going to suffer. With regards to the term Latino or Latina and Hispanic, I have a little bit more experience because growing up in Paraguay, my home country, in the heart of South America, I was very much at the forefront of the conversation around what it means to actually be called Hispanic, right? And how it sort of ties to the colonialism of the southern part of the Americas. And it ties to a descendancy from Hispania, which is Spain. It doesn't necessarily represent the culture of the folks who now live in South America and Central America. And so I began using Latino quite comfortably because, for me, it represents that the culture that I embody, and sort of disconnects me from the history, which I don't identify with as a Paraguayan Latino or Latinx. But now it's in what I've seen a lot, and in these in more recent times as it's being written, is that Hispanic is used to refer to the language, the Spanish that was derived from Hispania, and Latino or Latina or Latinx is utilized to refer to the geographical location and really encompasses a little bit more of culture, which of course, if you think about the Brazilians in South America, don't even speak Spanish, so Hispanic would not fit them in any way. So it's more inclusive, and I think that in our communities as Hispanics, and I'm humbled to be sharing my thoughts and my journey here with many other Hispanics, and these are only my thoughts. So I welcome a conversation around this, but the idea is that as Latinos or Latinx, we're still trying to find the right ways to represent who we are and the nuance and the complexity of our people. Because even within South America, the Paraguayan culture is very unique and in many ways very different from, let's say, the Chilean culture or the Venezuelan culture. Yes, there are some crossovers, but we're very distinct in many ways. And so I think it's important to keep all of these things in mind as practitioners. Why? Because Casa de Salud does not just serve Paraguayans. I would love for there to be millions of Paraguayans in St. Louis. It'd be great for me, but there aren't. In fact, there are precious few. We probably serve people from Mexico and Puerto Rico and Venezuela and Argentina. And so we have to be open to the fact that folks are comfortable with the spectrum. And so what we try to do, much like you've done today for this event, is we try to really embrace whatever folks are comfortable with in the moment, so that we in particular, Casa de Salud, can provide service. We can have a conversation about the terminology on the side, but that's not really where our mission is focused. So for us, it's really important to be very open and embracing and inclusive of where folks are. I mentioned that a little bit earlier. I think that Casa's main focus, especially as we're responding to COVID, is to really meet people where they are and understand that in many respects, human beings are always on a journey to learn more, to be better, to improve the ways that we treat each other. And this conversation around Latino, Latina, Latinx, Hispanic is a very good example of how we're processing that and learning how to treat each other with more respect. And so that's why it's a conversation that I'm very passionate about. I'll say one other thing as I was kind of putting my thoughts together around this, because again, we could spend the entire rest of this panel, I promise you I won't, talking about this. But I was just flipping through Facebook, and I saw a news article, I think it was NBC, that said that Eva Longoria was putting together a group called Latinos in Action or something like that. And the literal, I'm going to read it to you, the title of the article was Eva Longoria, Latinos Rally to Erase Inequities as Coronavirus Devastates Hispanics. So in the same title, they utilize Latinos and Hispanics. And to me, as a Hispanic or a Latino, I guess I have descendancy from Spain, so I speak Spanish. To me, it was confusing. So I can't imagine to someone who, only represents one or potentially none of those terms would be completely confused. What is this? But I say that, and I want to end on this, to say that what's important today, I think, is that we are inclusive and receptive so that everyone can receive the message, the information, the dialogue, the conversation that they need. Because otherwise what happens is, I think very unintentionally in many cases, we other parts of the community. And I think Julia mentioned it very well. What we're seeing today in terms of the rates of COVID in the Hispanic community, and before that there was a lot of great information on how it's decimating the Black community, isn't about those communities. It's about structural inequities. It's about problems that we have known existed in the healthcare system and access and equity to those services that have become a feature of COVID. And so in many ways, COVID is giving us an opportunity, should we accept it, to address not just today's problem, which is getting information to folks so that they can better be empowered to serve their own communities in terms of being safe during the response to COVID, but also breaking down some barriers more mid and long term, which we have known are there, and which there is a plethora of data to support. So I'll finish with this one last thing. I was recently reading an article that in Chicago, they're taking a much more comprehensive approach to disseminating information around COVID and the response to COVID. And they're thinking about this not just in the short term, but also in terms of addressing wealth disparities and racial inequalities that, again, have been known to us for many, many years, and taking the opportunity to do that because we're already late to the game. And so why not take this opportunity? And I think that folks in St. Louis can really learn from that and take energy and inspiration from it, because we have a good system here. We've got a lot of good people. We've built, if you will, a very good village of concerned folks and organizations. And there's no reason why we can't take this opportunity to address today's problem, but also the structural and historical problems that have led us to have in many ways, the problem that we have today.
And would anyone like to add to that?
I think for me, as a both public health researcher and mental health clinician, I work on this community engagement kind of level, in which I'm not interested being in the ivory tower, and doing that work from there. And so I think, when we see the kinds of pain and suffering that people are having, and we talk about what factors lead to those things, there's like this very common terminology in public health called, social determinants of health, like what determines the way your health is going to play out, to what degree, the risk factors, et cetera. And there's always, and I teach a class on public health policy and advocacy and trauma-informed care. And so one of the things we talk about is social determinants of health. And so people, name it off as though it's like every other thing that you've always heard in public health work, right? Like age, your race, ethnicity, your gender, et cetera. And so, I really think that when we're talking about race and ethnicity, and that we're saying like that's a social determinant of health, really what we're saying, and this kind of goes off of what Diego said earlier, is that we're not really talking, we're talking race, but we're really talking racism. And so I think that when we're talking about social determinants of health, I think it's really important to really say that when we're talking about, yes, age, gender, your economic wealth, et cetera, but not just race, but racism is what has led it itself to the types of comorbidities that we're seeing now. And so for me, being able to do the work on the ground is super important. That connectedness to the community and what the community is saying, and really being able to bring that back into a place where there actually can be movement, I think is super important. I think that, people feel stuck sometimes as to know what to do or what to do with the privileges they hold. And I think that, sometimes it's not really about, it's okay to feel stuck, right? It's okay to not know, but then if you kind of sit in that for too long, then another thing passes, another piece of time passes, and we find ourselves in the same situation as, as if we were just replaying the day over and over again, or history over and over again. And I think that for those reasons, my work as it relates to LGBTQIA, COVID disparities, immigrant health, Latin health, and considering like, what does that look like when we talk about sex, sexuality, and, how does that then look in the space of COVID and what people are experiencing, and kind of what my other colleagues have talked about here about like the language barriers, but then also the cultural differences, and how do we become, open or more open and notice our implicit bias. And I think that becomes one of the very first and early steps that a person can take. What bias do we hold? I literally teach anti-oppression course, but does that mean that I don't have my bias however they come? And I most definitely do, and so being present to that and saying, how can I make sure that I am not somehow imposing, personal preferences or beliefs, which I think Alexandra Johnson mentioned, which Alexandra, thank you much. Like, I think that those, yes, I hold representation in identities, some identities that keep me in a marginalized group, and other ones that hold that I have privilege, right? The education that I've been able to attain, for example. And I think that, there is something to be said about how we go about interacting with people, and especially during a time in which everything is so uncertain and people's mental health are at the kind of at its, maybe brink. And how do we bring and how do we engage folks in a way that they can engage more their emotional bandwidth? And this may be the first time they've ever been able to do that, or maybe they've never had the opportunity, so they don't have the coping skills or the techniques to know how to. And so I think that, the importance of not only the physical health, but the mental health of the person cannot just be, dissected into two, but always has to be present as all encompassing, as we are humans of all things and all matters. And so we have to consider, what does the mental health do to the physical health of someone, and how much that is perpetuated or, stunted or stigmatized, depending on, your family dynamic, your social dynamics, your cultural dynamics, and then what people are telling you you know, on the day to day. And I think that breaking down those barriers are going to be a continued process. You know, I wish it could just be done and we wouldn't have to be doing this kind of work and that everybody would be on that similar page. But unfortunately, you know, we have still plenty of work to do. And especially when we think about cultures and the differences in cultures and how do we engage in those conversations without being disrespectful or, you know, being too forceful with our own personal beliefs or thought processes, while being able to listen to the opinions of others and being able to understand, like, what is it that I'm trying to support and how do I come to those understandings versus trying to diminish what the other person is saying, explaining your stance in the way that you need to, so that the disparity that we see in something so blatant like COVID, you know, has a more optimal space for conversation and then, you know, action. Because we can talk all day, but if we don't really do anything about it, then I think then we're still again in the same boat. And fortunately, we do have, you know, as Diego said, like a village of folks that I think really do have the best intentions and are acting on those intentions. And I think that that ultimately is going to be where we see change.
Yvonne, I'd like to ask that we know language can be a barrier to information and care for a lot of people in trying to address these disparities. How do we best take into account those with limited English proficiency? And you talked a little bit about translation services, but I was wondering if you could give a little bit more detail about the whole process.
Well, I think adding to that is that when you are not fluent in the language, you are missing not just the components of the service that you're being presented at that moment, but, you know, sort of rewind and start with even where to find a service. So, or how to navigate the community in general. So you're learning a monetary system, you're learning a culture, you're learning a new place, and a system for healthcare, where here, you know, the system is very formal, and depending on the culture that you maybe have lived most of your life in, that may not have been quite as formal. Where here, for the most part, you have to make an appointment and you have to be, you know, on time for that appointment, and then there's a referral system for many services. You don't just show up. So you know, that's one component, and then everything that follows that, you know, from picking up your prescriptions, for example, at the pharmacy. So then encountering again another situation where you have to understand how to take this medication. What does it say on the bottle? The bottle's probably not printed in Spanish or whatever language you speak. So there's a lot of things, and then you're referred somewhere else, and then that referral also, whatever you're referred to, will you encounter then another set of challenges in terms of the language barrier and expectations. You know, you have you know, the payment expectations and understanding how a bill works. And even in English, for those of us who are fluent, when we receive, you know, some of these healthcare bills, and if you happen to have insurance in your home, you receive these mailings, you know, they're complex. So having language access, interpretation access for those who are not fluent throughout the continuum of, you know, being able to access and then following through treatments and accessing additional services. Those are huge challenges. At Afenia Healthcare, with the resources that we are able to secure through grants and donations and other sources, you know, we provide quite a bit of this kind of navigation service. We have community health workers, we have outreach workers, and we have staff at all of our locations. We do have 2 pharmacies. We have lab within our facilities, for example, so that we try to eliminate as many of those hands off for referrals as we possibly can, so that when someone comes into Afenia Healthcare, we have video interpretation at all of our stations, so that somebody who stops in at reception or to see an outreach worker to fill out some forms, or at our pharmacy, or go to the lab area, if the staff there themselves are not fluent in Spanish or Arabic, Farsi, Dari, or whatever language that they might speak, that we do have a way to effectively communicate with the patient throughout the continuum of services that we provide. And again, removing as many barriers. We provide optometry with a partnership with UMSL University. We have audiology services, and that's a partnership with the Center for Hearing and Speech. We provide behavioral health services that include substance use disorders, medication-assisted treatment services. The opioid crisis has not gone away, and that is really a big concern, with St. Louis being accounting for about 70% of overdoses in the state of Missouri. So we have to be not forget that in the middle of this, who need prenatal care, there are children that really need to be getting their immunizations on time. So providing these messages to the community is definitely a higher level of challenge when the language is a barrier, as well as all of those steps that I described, and the cultural piece. So everyone has already mentioned this factor. So it's not just language; it's also the cultural awareness of what maybe occupying somebody's mind, what they're worried about. So really active listening, open-ended questions, those are really important, so that we can truly understand where somebody's coming from, and taking it from there to effectively provide care that then they're going to follow up on.
Dr. Gay, I wonder if you could provide kind of a clinical perspective for this question from Anthony about inherent biases that may be at the professional-patient interaction, and how to address some of these issues.
Yeah. If you've interacted with different people from, different countries in Latin America, you get a sense of their culture. We had a project, for example, in Guatemala. We're collaborating with their cancer center. And when we did an assessment of their cancer center, knowing the language and being a little bit more familiar with our culture, we got so much more information that was useful, as compared to not being familiar with the language and people being comfortable sharing information. I think the language is probably the easiest part. We have translators at the cancer center that can facilitate that conversation. That, I think, is easy. I think knowing the language, in my experience, helps the patient feel more comfortable and be more open, and it reduces the anxiety quite a bit. That's harder to replicate with that translator. I think it's more intimidating when your doctor is speaking another language, and the patient could be suspicious of the medical establishment, or that I see as an issue, and it's harder to address. The other thing is cultural differences. How, like in Puerto Rico, like you might have an anxiety or depression, and it might be an ataque de nervios or something like that. That knowing those terms could help you more more easily understand what the problem is and how to address it. Those cultural differences, it's harder. We come from different countries. How we express ourselves in terms of medical terms, how the home remedies are different from whichever country in Latin America you come from. And to train somebody for that, it's even harder. And we see a few patients, mainly I would say from Mexico. So I have some patients maybe from Venezuela or Colombia. But in terms of cancer patient population, it's really a minority that I've seen over the years come through our doors. I think in the primary care area, the patient population seems to be much larger. And I think, that perhaps is a higher yield area in terms of investing in all these resources.
So Ashley, if I could I just jump in? This is something that I think is really, really important. The idea of cultural competency, and as Julia mentioned, cultural humility. And I want to give one clear example. During COVID, due to concerns of keeping hospitals as safe as possible, folks have been asked to go to the hospital alone with no accompaniment, right? To reduce the number of people there, to reduce the risk of transmission. Full stop, that sounds like a really good idea. But when you think about it within the context of different cultures and approaching it from the way other cultures expect to receive healthcare, that's not how Yehuavente, the Paraguayan, goes to the hospital or to the doctor's office. The entire family goes, and that's just me. So collectively, my unit is one, counts for one. And so when hospitals are now saying, because of this risk of transmission, we're asking folks to show up on their own, that's a huge deterrent, right? And so we think about the famous image of equality versus equity, right? And then systemic inequalities. And so, I'm not saying that there's an easy answer to that, but I'm saying that if we don't acknowledge those challenges and how those challenges have implications and affect the outcomes that we're seeing right now, then we're missing the target here. And then the other thing is, let's assume that the Diego Paraguayan is willing to go to the hospital on his own because he really is concerned about his health care, and I'm willing to leave the other half of me, my family, behind. I still might want to bring an advocate or someone who can translate for me, who's from my family or who I know, rather than being offered that service by someone who I don't know, right, over the phone, or someone who's just brought in, or even humbly, Dr. Gay, who is probably awesome, and I'll get to know him, but as a Latino, we got to get to know each other. We got to talk to each other about our families and where you come from and how long have you been here and where you live, and do you like pizza, and is it thick crust or thin crust? Because otherwise, man, we can't get to know each other. And all that can't happen necessarily in every single medical encounter, yet it very much influences the conversation from a cultural perspective. And I mentioned these things so that we can understand that this is nuanced and complex, and we have to address all these things if we want to create equality or equity in the way that folks are accessing care, because it is part of who we are and how we represent as we access, and I speak as a Latino, Latinx, how we access and what we expect to access when we go to get and seek healthcare.
And I'd like to add even more to that. So that tells us right there, we all have so many thoughts around this. It is complex. That many immigrants, and I also want to punctuate that not all Hispanics are immigrants. Many Hispanics here in our community are born here, and they have Hispanic heritage. And so some of the cultural norms of their heritage are still part of their lives, although maybe the language is not. So we want to acknowledge that. But aside from that, for those who are immigrants, a lot of us have found ourselves in a situation where, we don't have that extended family that you grew up with here. And so, for example, when my baby was born back a number of years ago, I was fortunate my parents could come and spend a few weeks with me, and then they were gone, back to Venezuela, where I'm from. So, so you find yourself, you grew up a certain way, and then you move somewhere for whatever, all the different reasons that you do so. And now you don't have that extended family. So for some people, if they also have the language barrier or other, isolation for other reasons, they're new to the area. Simply, when you're new somewhere, you just don't have that extended support. So finding ways in which people can connect more with each other is important for well-being, for emotional well-being, just to even answer questions peer-to-peer, that's very important. A couple of ways in which we do that at Finia Healthcare is that we have care that under the centering pregnancy model for pregnant women, centering parenting for new parents, and a number of other group kinds of activities, which right now we're challenged to provide because of COVID-19. So that is another way in which COVID it has impacted all of the community, but in particular, any community individuals that face a certain degree of isolation. Now they're even further distanced, isolated, and not everybody knows how to use Zoom or has access to technology that is reliable. So then you have that additional barrier while you are sitting there wondering what should I do? Where should I go? Should I do something or not? And where does caring for my health and any kind of symptoms of worry that I may have come in all of the other priorities that may be other worries for me in my life. So while we hope that health comes first, or at least second, food might come a little bit before that, without health, then people will face greater barriers to everything else. If you let your health deteriorate, then you can't go to school, you can't hold a job, at least adequately or appropriately or effectively, I should say. But so isolation is something that I think very much impacts also the community. And then, as Diego said, if then you're faced with other kinds of isolation, even if you do have a support system, now you're kind of cut off from that support system.
Well, thank you so much. We're at the top of the hour here, and I just want to thank you for your perspectives and time and insight into this topic. And thank you to all of our attendees. And we look forward to hosting the next panel. So thank you so much.
Thank you all.